Good evening, everyone. Welcome to tonight's webinar. My name is Dan Green. I'll be your host tonight. Tonight is Sunday, August the 8th, 2021. Given that it's a Sunday, we will be doing cases from folks' case lists. So I will ask for a volunteer in a minute, and we'll pick out a case. We'll try to rotate through, GYN, OB office, and back again. So if I could get a volunteer for the hot seat, that would be great. Or not? Okay. Ashley, we're trying to pick on you. It says you're self-muted.
Hello.
Hi, Ashley. How are you?
I'm good. I was actually going to raise my hand. I was trying to get to my button. With these wireless headphones, you can kind of do whatever you want to do.
Yeah, we beat you to it. So are you a generalist or
Cool.
a specialist?
I'm a generalist.
Okay, so one thing I would like to mention to you as well as everybody else on the call, please do send in your case list to ExamPro so that they can load them so that we have them and we can work from your list. I don't have your list up. Did you send it in yet?
You do. I submitted it. I was actually in this the Zoom course that ended on Friday, so you do have it, and I had resent it once I bought this package. So I'm happy to tell you my last name if the stuff from the course from last week is still in there.
Yeah, let me hang on one second. I think I can probably go back to the webinar. Or sorry. Nope. Yeah, I'm sorry. I don't have access to last week's. I think they took it down, the board.
Okay.
So sorry about that.
That's fine.
Give me one more second.
Practice,
let me just see if I. Nope, not there either. I'm sorry. Yeah, if you could maybe shoot them an email tomorrow or whenever you get a second.
Sure.
Maybe they may still have it on their system and they can transfer it.
Yeah,
Okay.
I can resend it.
So
all right.
Great. I'm sorry. All right. So we are going to pick a case. All right, so patient number 3 on this person's GYN list is a 47-year-old G2P2 that had an endocervical polyp, had a history of an endometrial ablation, was having abnormal uterine bleeding. They did a DNC operative hysteroscopy with polypectomy and diagnostic laparoscopy. Showed Nabothian cyst, benign endocervical polyp, and had a uterine perforation in the posterior uterine wall. So tell me, first of all, in the POM-COIEN system, what does each letter stand for?
Sure. The P in POM stands for polyp, and then adenomyosis, leiomyoma, M is for malignancy, and C, I always forget, so I'm going to skip that. O is ovarian. I believe is iatrogenic and is not otherwise specified. C perhaps might be cervical.
Okay, there's also an E in there as an Edward. Can you tell me what the E stands for?
Endometrial.
Okay. So can you give me an example of an endometrial cause?
Yeah, sure. Endometrial hyperplasia, for example, or thickening of the endometrium.
Excuse me. So would endometrial hyperplasia fit under endometrial cause, or would that be under malignancy?
Well, technically, endometrial hyperplasia can be like a pre-malignant cause.
Okay, so does the M count pre-malignant or only malignancy?
I believe only malignancy.
Okay. So what's the difference between the POM and the COIEN? Why did they divide them out like POM is one thing and COIEN is another?
POM is structural, like anatomical causes, and the COIEN part is non-structural, so the E obviously doesn't that's not endometrial because that doesn't fit.
So I'm sorry, you said the E would not fit under structural based on
under non-structural, yeah.
Okay. So let's see. So this patient had an ablation previously. How effective are endometrial ablations at improving a patient's bleeding?
Well, I think one of the key things in counseling a patient who is considering an endometrial ablation is that not everybody achieves amenorrhea. I believe 5% of the patients who end up having an endometrial ablation eventually go on and have a hysterectomy because they're not happy with the kind of bleeding that they're having. So
I'm sorry, what percent?
I believe 5%.
Okay.
So I typically counsel these patients to expect less bleeding, but not necessarily amenorrhea, because that could lead to a dissatisfaction with the expectations for this procedure.
So overall, what percent of patients would you do you counsel patients have at least improvement in their bleeding? And improvement could be anything from amenorrhea to less bleeding.
Like 50% improvement.
So what anatomic factors reduce the effectiveness of an ablation?
Anatomic factors, so size. So a cavity that is too small or too large may be inappropriately or suboptimally ablated. The contour obviously has to be taken into consideration. A cavity that is impinged by many fibroids may also have difficulty being successfully ablated. Those are the main two that I think of.
Okay. Last question. So I don't know if you can see the list at all now, if it helps to see it or not. But anyway, it's patient number 3.
Number 3. Okay.
So she had a perforation. So when you do a DNC hysteroscopy, what's the incidence of perforation?
The incidence of perforation is somewhere around 1 to 2%.
Okay, and what are risk factors for perforation?
Risk factors, so looking at the patient herself would be anatomical. So if she has particularities within her cervix, say a stenotic cervix, particularities within the uterus, so a retroverted uterus. If she has other things that distort the normal anatomy, so if she does have big bulky fibroids that are causing an abnormal uterine bleeding, those certainly can affect her, as well as a surgical history. So C-sections can sometimes, pull that uterus into kind of tack it up, for example. So those are things related to the patient itself. Otherwise, when we're looking at the operator, obviously operator experience can play into it. Someone who's done, while everyone we say is there's no one who is immune to perforation, typically experience can help mitigate the risk of perforation. Here.
Okay. All right. Very good. Thank you. Thank you for letting me pick on you. So let's go over this one. It was you did a nice job. One thing a comment I would make to you and also to all the folks listening in. Now, look, I know, Ashley, this is not your list, so take what I'm saying with a grain of salt. But if this were your list and you had the perforation, I would not. You're right about operator experience and what have you. Totally agree with you. But that would not be something I would bring up.
Dig the hole.
Well, the reason I wouldn't bring it up is, first of all, you gave me a bunch of other reasons why a person might be at risk for perforation. Okay. And when you say operator inexperience or something along those lines, indirectly, it plants the seed in the examiner's mind. Hey, Does she just not have enough experience to do D&Cs? Is it something that she's technically doing wrong? Again, we all know that's a possibility, but it's one thing knowing it in the back of your mind. Maybe we think about it, maybe we don't think about it. It's quite another thing for you to say operator inexperienced, because again, then the seed is planted. It's like, why is she thinking operator inexperienced, and why is she bringing that up? So personally, if it, again, if it's a made up case, certainly you could bring it up. But if it's a case, and again, I know it's not your list, but if it were a case from your list, I would definitely not do that. Anything that's going to even suggest or paint us in a compromised light, we don't want to bring up to the examiner.
Okay.
Even though, as we all know, you do enough D&Cs. If you haven't had a perforation, you haven't done enough D&Cs, is what we used to say.
Right, exactly. Yeah.
But, there's plenty of reasons why folks have the perforation short of, inexperienced or poor technique. Make sense?
Yes.
Okay. All right. So your palm cone, you were correct. So E is endometrial, by the way. An endometrial cause, and this is one of my favorite stupid questions, but an endometrial cause would be something like either atrophic or infectious endometritis.
Okay.
Endometrial hyperplasia, again, if you think about it in the purest sense of structural versus non-structural, you could hold a patient, you could hold cancer, a clump of cancerous tissue, a cancerous polyp, or a piece of the uterus. If we're dividing it up in the pathology lab, you could hold that in your hand and say, "Yep, this lady's got cancer." That's a structural issue. You can't really hold, for example, an iatrogenic cause. I mean, yes, you could hold an IUD in your hand, but it's not actually what's causing. It's not actually what's bleeding. It's the tissue. You can't hold, for example, an ovulatory cause. You could hold the ovary, but you're not going to be able to hold hormones, for example, in your hand. So if you think about hyperplasia, if you scrape off a D&C specimen's endometrial hyperplasia, you could hold that in your hand. That's a structural thing. So malignancy includes hyperplasia and as well as frank malignancy. So the C is coagulopathy as opposed to cervical.
Thank you.
Sure. And the I is iatrogenic. I think you said that. The E, we talked endometrial, and the N is not otherwise specified. Of course, the O is ovulatory. So typically like your PCOS patient, or even though you're, thyroid disease patient, or prolactin for that matter, all ovulatory, excuse me. So the incidence of perforation is about 1%. I thought you did a nice job in terms of telling us what can cause it. From a structural standpoint, so depending what kind of ablation you do, 50 to 70% of patients will have improvement. You're right, it's a smaller percentage are going to have amenorrhea. Again, best case scenario, depending on the instrument, you're talking 30 to maybe 40%. But up to 70%, even some would show as high as 80, have improvement in their bleeding. And then about 10% are worse, and roughly 10% are no better. So you told me size, contour, which are both good. Polyps would be another thing that kind of fits in with fibroids that would reduce the effectiveness. And one that folks don't think about all that often, but adenomyosis would be another reason why they're not quite as successful. So, you could say a misshaped uterus, like a congenital abnormality or anomaly, but if a patient has a congenital anomaly, we probably shouldn't be doing an ablation on them in the first place. Any questions about this one?
No, I think you touched on everything.
Very good. Well, thank you for letting me throw you in the hot seat.
Absolutely, my pleasure.
Great, thanks. Okay, so Ebony, it looks like you either have a question or you're volunteering. I'm going to construe that as a volunteering. And I'm trying to, it says you're self-muted.
I actually have a question.
Oh, well, you have a question, and guess what the good news is? You're also going to be in the hot seat next.
Oh, I'm so excited. I think I missed you answering the question regarding the incidence of perforation with a DNC.
Yeah, so it's about 1%.
1%, okay.
Yeah. And things that can cause it, I think Ashley gave us a nice list. Cervical stenosis would be certainly up there, postmenopausal. I'm not sure if she mentioned recent gravid uterus is going to put you at increased risk. She did mention, I know, severe aneversion or retroverted uterus. She mentioned things distorting the cavity also could put a person at risk for perforation.
Okay, thanks.
Sure. Ebony, are you a generalist or specialist?
Generalist.
Okay, well, the good news is we're up to OB, and we also have your list. That's another good news. An oldie but goodie. All right, so patient number 2 is a 22-year-old G1P0 at 39 weeks with PROM. She had preeclampsia with severe features. She was induced, had blood pressure monitoring and laboratory evaluation, mag sulfate, intrauterine pressure catheter. She had a primary C-section for arrest of dilation and a postpartum hemorrhage, for which she gave uterotonics, a blood transfusion, and started her on iron. The baby was 4140 with 7 and 9 Apgars. Okay, so you ready?
Yes.
So first, can you tell me the definition of arrest of dilation?
So once the patient is past 6 centimeters and she's ruptured and on Pitocin, not making significant cervical change within 4 hours of adequate contractions and 6 hours of inadequate contractions.
Okay, can you tell me how you would determine adequate contractions?
For this particular patient, I inserted an intrauterine pressure catheter and monitored her Montevideo units. The goal is to have greater than 200 that would qualify as having adequate contractions. And in this case, she did have adequate contractions, but over the span of 4 to 5 hours did not make any cervical change.
Okay, so she had a postpartum hemorrhage. Tell me, what are risk factors for postpartum hemorrhage?
Prolonged induction, multi-parity or multi-gravid uterus, prolonged use of Pitocin, magnesium sulfate, preeclampsia in this patient's situation as well, C-section.
Okay. So you have uterotonic agents. So for this patient in particular, what would you typically use as your first go-to uterotonic?
I would avoid Methogen, but I started with giving her Hemabate in addition to the Pitocin, and then she also received TXA or tranexamic acid.
So what are contraindications to tranexamic acid?
Coagulopathy, history of prior or active blood clots. I think that's it.
Okay, and how much, you said you gave her Hemabate. How much Hemabate did you give?
0.2 micrograms of Hemabate.
0.2 micrograms?
Yes.
Okay, and how often can you give Hemabate?
I think it's every 6 hours you can give. I'm not exactly sure.
Okay. So let's see. She had preeclampsia with severe features. How do you make that diagnosis? So what are the criteria that make it quote unquote severe?
Well, there's several different criteria that can make it severe, whether it's severe range blood pressures greater than 160 systolic, over 110 diastolic. You could also have signs or symptoms of end organ disease, so elevated liver enzymes 2 times the normal limit, elevated creatinine, neurological symptoms, headache, vision changes, right upper quadrant pain.
Okay. Let's see. I'm sorry, I'm making notes while we're, for me to write and talk, that's a a big challenge. So how long do you treat a patient with seizure prophylaxis when you diagnose preeclampsia with severe features?
I typically keep them on magnesium sulfate for 24 hours after delivery. So as soon as they have the diagnosis of preeclampsia with severe features, I start them on magnesium and then continue it for a minimum of 24 hours.
So what are contraindications to magnesium?
Let's see. Oh, I'm sorry, I'm drawing a blank now.
Okay. Let's assume myasthenia gravis was one.
Okay.
So how would you treat this patient if she had myasthenia on top of everything else?
I wouldn't be giving her magnesium.
Okay, that's a good start.
Regarding her seizure prophylaxis?
You tell me.
Well, I would be monitoring her blood pressures the same as I would with someone who didn't have myasthenia gravis. And then if she were to have a seizure, then I would avoid magnesium in this case.
So would you treat her with anti-seizure medication or would you just observe her?
I am not exactly sure because I haven't treated a patient with myasthenia gravis and preeclampsia, but I probably would just observe her.
Okay. Let's see. Anything else? I'm just trying to think if there's anything else I want to bother you about with this one. I think that's it. So you can breathe again. I'm going to bring in a colleague of yours, and we'll see if they have anything to add. Samantha, I'm trying to unmute you. Samantha? Samantha's not talking to us. Tiffany, how about you?
Hello.
There's Samantha.
Sorry.
I thought it was something I said, maybe. Anything you want to add, change, or anything with Ebony's discussion?
Well, as far as the not using not using magnesium sulfate in a patient with myasthenia gravis, I agree with just performing serial blood pressure monitoring and just watching her blood pressures closely. I would consider starting some sort of antihypertensive therapy or medication. And then for
what would you give?
Depending on, I'm going to shoot myself in the foot with this one. I would consider, it depends on what the heart rate would be, but hydralazine, I would consider giving that.
What does the heart rate have to do with it?
We don't want reflex tachycardia, so I wouldn't want to give it if it's too high.
Okay. Is there anything else you could give other than hydralazine?
I would consider labetalol.
Okay. How much labetalol would you give?
I would start with the lowest dose, so about 100 milligrams, and titrate up as needed.
Would you give it to her orally or IV, or how would you give it?
I would give it orally unless she was having severe range blood pressures where she would need the agent a bit faster.
Well, if she's preeclamptic with severe features, again, it's not a 100% guarantee, but isn't she most likely to have severe range blood pressures?
Yes, so IV.
Okay, how much would you give IV?
I would give 20 milligrams in that case.
Okay. So anything else that you want to comment with respect to what Ebony was telling us? Either agree, disagree, or add in?
And I'm kind of came in late, so I agree with the blood pressure monitoring, and I'm sorry, forgive me. Did the patient have a seizure, or we were just considering seizure prophylaxis?
No, we're saying if the MAG were contraindicated.
Right. Yes, I would observe the patient as well. I agree.
Okay. All right. Very good. Thank you. All right, guys. So let's go over it. I'm going to put you back on mute, Samantha, and you too, Ebony. Thank you. All right. So a couple things. So arrestive dilation. Nice job, Ebony. You hit it on the head. So my point, and again, I think we talked about this maybe even the other night, but you must know every definition on your case list. So I'm going to continue to hammer you guys up until your test. So not just with arrestive dilation, but arrest of descent, failed induction. If you had somebody with severe variables and you had it on there, again, I'm going to hammer you guys with definitions because there's nothing that's going to make you, well, almost nothing that's going to make you feel as silly as if you can't accurately define something that's actually listed on your list. All right, so good job there, Ebony. I think one of the things I asked you was causes of postpartum hemorrhage. So, you know, remember there's both immediate and delayed postpartum hemorrhage. So for immediate postpartum hemorrhage, certainly the most common thing is going to be a uterine atony. And I think you gave us several examples of what could cause uterine atony, Ebony. But let's not forget, you know, uterine atony is only one thing that can cause postpartum hemorrhage, and certainly in the immediate phase. So we would be thinking for this, well, let's go through the uterine atony. You mentioned magnesium, you mentioned, I think you said multiple gestation or twins. So large for gestational age, certainly diabetic patients would be at increased risk. You mentioned magnesium. Infection would be another. Prolonged induction, I think you may have mentioned that. So basically, anything that's going to over-distend the uterus could result in atony. Gram multiparity would be another example. But in addition to uterine atony, there are other things that can cause an immediate postpartum hemorrhage, such as a vaginal or cervical laceration. Could retain products of conception certainly could cause a postpartum hemorrhage. Obviously, if a patient has a coagulopathy, she's going to be at risk for postpartum hemorrhage. In terms of delayed postpartum hemorrhage, the couple things that come to mind would be infection, retained products of conception, subinvolution of the placental site. So those would be just a couple things. Now, in terms of treatment, so guys, again, we're 3 months away from the test for the earliest test takers. So not being critical in any way, but this is a pass-fail question in terms of postpartum hemorrhage. You must know all your uterotonics, dose, side effects, contraindications, frequency of administration. So, you know, Pitocin typically would be where we would start, and you could certainly give 40 units in a liter, and you could run it fairly quickly. Normally, Methergin would be our next step. Obviously not in this case in a patient with preeclampsia with severe features. And that would be 0.2 milligrams. And we would typically, in a situation like this, give it IM. And you can give it every 4 hours for up to 6 doses, albeit you could give a second IM shot if you needed to in 2 hours in the case of a postpartum hemorrhage, albeit the normal dose is, again, every 4 hours. So please make sure your units are correct. Ebony, I think you told me hemobate was 0.2 micrograms. So we could give 0.2 micrograms all day long because that's like a spit in the ocean. So the dose for the hemobate would be 250 micrograms, and we can give that IM every 15 minutes for a maximum of 8 doses. Folks would then often use Cytotec, and it's 800 to 1,000 milligrams per rectum. And I think that's it for the uterotonics. Then normally next would be a DNC and/or a tamponade device. Tranexamic acid, as long as it's within 3 hours, can be given. Ebony, I think you mentioned coagulopathy was a contraindication. That's not, people always mix these two up. It actually would be a thrombophilia that would be a contraindication. Coagulopathy might be a reason we would give it, because coagulopathy, they're bleeding too much. Thrombophilia, they're prone to bleeding. They're prone to clotting, excuse me. So certainly somebody that had an active clot, especially if it were in their head, and you guys will laugh at this one, but color blindness is another contraindication, acquired color blindness, because I think it's something with seeing green or something like that, but it's one of the parameters you can look at for toxicity. So kind of goofy. I remember when I read that, I was scratching my head. Okay, so magnesium. So contraindications to magnesium. So myasthenia is one of them. Be a patient in renal failure, we would not want to give magnesium, which is why we have to be so careful when somebody's oligurine. So if you had a patient that you were concerned about seizure prophylaxis, other medications that you could use would be phenobarbital, and the other thing you could use would be a benzodiazepine. So either of these would be things to consider, especially after delivery, for a patient that we were concerned about seizure prophylaxis. And then in terms of treating the blood pressure, so Samantha, you mentioned the hydralazine, but then you got into the heart rate stuff. I wouldn't actually try to qualify it if you're not sure too much from a technique standpoint. I would just, if you're going to go with hydralazine, just say hydralazine, and they might come back to you and say, well, what if the patient's tachycardic? And then you could, qualify it. But if you're not certain, why volunteer it, kind of thing. And I don't mean why volunteer the hydralazine, but I mean why volunteer the caveat is what I'm getting at. But labetalol certainly would be, especially if the patient's tachycardia, would be certainly a good choice. And 20 milligrams, if we were going to give it IV, would be where we would start. I don't think I asked you, Samantha, what the mechanism of action of labetalol is. I unmuted you again. Can you tell me what it is?
Sorry, mechanism of action of labetalol?
Yes.
It's a beta blocker?
Does it have any other properties?
I'm not sure.
Okay, so 80 to 85% of it is a beta blockade, and that is the rapid action. It has about 10 to 15% alpha blockade. That usually takes a little longer to kick in. So it's the majority of it is beta blockade. Just trying to see is there anything that we didn't go over that that you can think of, Samantha?
So for the phenobarbital and the benzodiazepines, are they going to ask us dosing for that and frequency?
Only
personally never used
only
that.
if you have only if you have it on your list. And I'm going back almost as far as residency for this, so that's like 100 years for those of you keeping score at home. I want to say phenobarb was like 30 milligrams, but again, that's like a 2% certainty. So I'm 98% just, recalling from 100 years ago, so to speak. But again, this is not an emergent situation. It's not like the patient came in seizing. Mm-hmm. If she comes in actively seizing and you have to treat her with something, you could treat her with like Ativan. I think it's 2 milligrams if I'm not mistaken. IM.
Okay.
She comes in without an IV. But in terms of prophylaxis, obviously you're going to have I don't say the luxury of a long time, but you'll have the luxury of some time to certainly check out the dose.
Okay.
The point is you could use something else, especially after delivery, because we don't have to worry about the baby, of course. if you're worried that she's at high risk for seizure. Again, to lower that or raise the seizure threshold, I guess, is probably the better way to put it.
Okay.
Okay. Very good. Thank you. Ebony, did you have any questions or comments?
No, I will definitely go over the stuff that I missed.
Yeah, so I'm sorry, I'm not trying to obviously make you feel bad. We're way away from the test, so don't think twice about it. But please do, the two things that are absolutely critical to know for OB would be management of postpartum hemorrhage. I mean, should be like the back of your hand, as should shoulder dystocia. Okay. You with me, Ebony?
Yes, I hear. Yeah.
Great, thank you. Okay, I need a volunteer, please. Guys are all now petrified. Like, I'm not volunteering for him. He's mean. Don't make me voluntold somebody. So, Ashley, do you have a question or are you volunteering, Ashley?
No, I can go again. If no one else wants to go.
I appreciate it. I'm going to voluntold somebody just so we get more folks on that. But thank you very much. Okay, so looks like Maria's volunteering. Not really, but she will be now. Maria, are you there?
I'm here.
Thank you for letting me volunteer you. One second. The good news is I got to grab a piece of paper. Okay, so let's see. I'm good for this one. All right, so patient number 4, and I'm not sure if we did this I don't think we did this the other night, is a 30-year-old G2P2, desires long-acting reversible contraception. Did we do IUDs the other night?
I can't remember if it was in the course or in the webinar series.
Okay, well, then you'll get 100 on it.
Oh.
No pressure. Desires LARC, basically. So you did a history and physical cultures, and you placed a progesterone IUD. So tell me, what's the incidence of perforation with IUD insertion?
I'm not positive of this number, but I'm going to ballpark about 5%.
Okay. This is a total, just me making you think about it. How many in your career, including residency, IUDs would you guess you've placed? Just ballpark.
Oh boy. 100?
Over 100?
Yeah.
Okay. Have you had 5 perforations, do you think?
Hopefully maybe 1, if any.
Okay. All right. So sometimes if you don't know the number, it's try to, you can think back on your experience.
Yeah.
Okay. So what are risk factors for perforation?
Well, so like we mentioned before, issues with the cervix. So if you have a stenotic cervix, the position of the uterus, the size of the uterus, any uterine pathology that you might not be aware of, such as a fibroid.
Okay. So how does the progesterone IUD keep people from getting pregnant?
So it works by increasing the cervical mucus and preventing the sperm from fertilizing the egg. It also thins the lining of the endometrium.
Okay. What about the copper IUD? How does that work to prevent pregnancy?
That might be the one I was thinking of. So that one definitely increases the cervical mucus to prevent the sperm. and it prevents,
Okay.
I believe it also prevents implantation.
All right. Are there any uses for either of the two IUDs other than long-term contraception?
The copper IUD can be used for emergency contraception. The levonorgestrel IUD can be used for patients that have abnormal uterine bleeding. If they want to decrease, I guess, their cycles or how much they're bleeding.
How many days post-exposure can the copper IUD be used?
I believe 5.
Okay. Do IUDs increase a patient's risk of ectopic?
They do not.
Okay. And what would you do? Let's say this patient calls you a year from now and says, doctor, I've been having some breast tenderness and some nausea. I did a home pregnancy test and I'm pregnant, and I've decided it's, you know, if I got pregnant after all this, despite my efforts, I want to keep it. So what would you do with her?
I would have her come into the clinic. I would do an ultrasound to confirm if the IUD was in fact in place and see if there's a pregnancy or do a pregnancy test when she arrives.
Okay, so you do a pregnancy test, you do an ultrasound, and then let's say she's pregnant, your ultrasound does not show an IUD. Well, let's say it does show the IUD. What would you do with the IUD?
I would first counsel her that having the IUD in place will increase her risk for a miscarriage throughout the first trimester. Or I guess I'll take back that first trimester because I wish I hadn't said that, but it would increase her risk for a miscarriage, and that it would be it should be removed. Although removing it will also increase her chance for a miscarriage at that time. But if the pregnancy continues after the IUD is removed, that concern for the ongoing risk for a miscarriage would be removed.
What about let's say you don't see the IUD strings, nor do you see on ultrasound the IUD in the uterus? What would you do next?
If she is pregnant, my next step, I believe, would be to suggest a diagnostic laparoscopy. If she was not pregnant, my next step would be to do an abdominal X-ray to see if it's in the abdomen and or elsewhere.
So would you do that with her being pregnant?
I wouldn't with the abdominal X-ray.
I'm sorry, you would or would not?
I would not do an X-ray if she was pregnant.
Okay, so she is pregnant, so you don't see it in the uterus. What are you going to do?
The diagnostic laparoscopy.
Oh, so you're going to operate on her?
No, I don't think I would. I'm going to take that back.
Well, how do you know if you operated on her that you're necessarily going to see it? First of all, you don't even know if it's there.
Right. That's what I said. I would probably not. So I guess I would. I would counsel her on the risks of X-ray exposure in early pregnancy, and maybe wait until organogenesis is complete to perform the X-ray.
Okay, so let's say you wait till the second trimester and you X-ray her and you find out that she does in fact, let's say the IUD is in the cul-de-sac. What are you going to do now?
I think I still want to get it out, so I think I would probably move towards a laparoscopy at that time, especially in the second trimester.
So you're going to subject her to anesthesia, and how are you going to manipulate the uterus?
I would not manipulate the uterus. I'm digging myself into a hole. I can feel it.
Don't let the dirt fool you.
Yeah.
Okay, let's rescue you. Actually, you're doing fine. You know, there is no absolute answer as far as this goes. We'll go over it. All right, so let's go over it. So I think you kind of got a sense for, 5% is probably a little high. I mean, that's what 1 out of every 20 statistically we'd be perforating. People would have a bigger deal to say about that. So the incidence is really between 1 in 100 and 1 in 1,000. So 0.1 to 1%. I think you did a nice job in terms of the risk factors, kind of similar to what we talked about with the perforation before. In terms of the ectopic, you're right. It does not increase your risk of ectopic or the patient's risk of ectopic, but if she gets pregnant, she's at increased risk of having an ectopic. So it's about 50-50 chance potentially. So in terms of the mechanism of action for the progesterone IUD, you were actually correct. You said it thins the endometrium, making it less hospitable for implantation, and it thickens cervical mucus. Excuse me. The copper IUD, on the other hand, is going to create a sterile inflammatory environment. So it is inhospitable for implantation as well, but for a different reason. And it's also thought to be toxic to the sperm, but it's not going to do anything about cervical mucus.
Okay.
You're right about the copper IUD with the 5 days post-exposure. And you're also, of course, right about the progesterone IUD with abnormal uterine bleeding, endometrial hyperplasia. Yeah. Let's see. So what are we going to do? I thought your explanation in terms of if we see the IUD and she's pregnant, I thought that was good, and I thought that was fine. Preferably, hopefully the IUD is going to be below the pregnancy if we're going to remove it. In terms of if we don't see it, so this is where there's no absolute right or wrong answer, but if the patient's asymptomatic, so not having GI problems, I would just leave it alone, because to x-ray her, let's say we x-ray her, and let's say we x-ray her after first of all, the radiation exposure is minimal for a flat plate of the abdomen.
Yeah.
But let's say we're uber paranoid and we don't want to do it in the first trimester, especially if she's asymptomatic. So we do it in the second trimester. Excuse me. If we do see it, I wouldn't go electively operate on her. Granted, it is second trimester, which would be the better time to operate compared to first or third. But kind of what's the point if she's asymptomatic? If she develops, GI symptoms, different story. But that thing could have been in the cul-de-sac for the past year. Could have been there since, since we placed it. So that's why I wouldn't do the x-ray, because I wouldn't do anything with the information. Now, if on the other hand, at delivery, the patient ended up with a C-section, I would get a flat plate on the table, because the belly's after the uterus is closed, but before the belly is closed, I would do a flat plate. And if I saw it, then I would go after it at that time. And again, of course, I'd give the patient precautions. Hey, if you develop severe abdominal pain anytime during this pregnancy, by all means, call me right away. And at that point, you got to do what you got to do. Does it make sense?
Yeah. I just need to learn how to back up when I'm digging that hole, when I'm like, this is not sounding good.
Well, you're not absolutely wrong with what you said, but you have to be able, but in the absence of an absolute, if A, you should do B. So if it's something that you're coming up with, you have to be able to defend why you're charting the course you're charting.
Right.
And all I have to do as the examiner to you is say, oh, so you would electively operate on somebody who's asymptomatic in the second trimester. And then you'd say to me, well, she could develop complications from this. And it's like, well, it could have been there for a year. Do you see what I mean?
Oh, yeah.
And again, whether you're right or wrong, it puts you automatically on the defensive.
Mm-hmm.
And I could argue it the other way if you told me you would do what I would do.
Yeah, right.
I might be able to argue it the other way, but, anyway. So it's kind of a interesting situation in terms of trying to see how folks think and if they can back up something where there's not a black and white recommendation.
Yeah.
I did read something somewhere, and I did read something somewhere that was kind of along the lines of what I suggested to you that I would do. But for the life of me, I couldn't find it for you if you ask me. So, but most of what I've read is it's kind of up in the air what to do. Okay, well, thank you for letting me voluntold you.
No problem.
Great. So what I'm going to do here, whoops, sorry. So Maria's back on mute. So does anybody have any questions about anything we discussed tonight or anything as it relates to the boards, either from a previous night, from the course, or, you know, caseless question type thing? I'll take those questions now, and if not, we'll go with another topic. Samantha?
I guess this is just a generalized question, and it may just be individualized, but what's just the best way other than these webinars to prepare for the exam outside of this hour period every, 4 nights a week, in your opinion?
Yeah, so a couple things that I usually recommend for people. Obviously, practice bulletins and committee opinions are key. If you have the Exam Pro prep course manual, it's going to give you a good basic foundation for pretty much all the topics that they might ask you. It may not be quite as detailed as you need for certain things if they pick on a particular topic. The good thing about it is, though, if you master that, you'll have something to say about everything. You may not be able to say it to the nth degree and, answer the 4th and 5th question in the series, but you should be able to answer the first several. So that's kind of a good, icebreaker in that respect. Again, the committee opinions, the practice bulletins. The other thing I would recommend, are you familiar with the Pearls of Excellence?
Yes.
Those are really good. Those, I was told, at least in the past, used to come from questions that candidates were asked that had difficulty on the oral boards. So the topics were derived sometimes from those questions. I mean, there's like all sorts of good stuff on there. 4th degree laceration that falls apart out, a couple weeks after repair, brow presentation, things of that nature.
Okay. That's helpful. Thank you.
That's my pleasure. One other thing I would tell you, Samantha, even though I have you on mute, there's no substitute for doing as much practice as you can in terms of mock orals. So, yes, I know it's expensive with Exam Pro, and I'm not suggesting you sign up for 100 hours of mock orals with us. I do think, a couple are beneficial, but putting that aside, you don't want to do it either, though, with your best friend from residency. I mean, that's better than not doing it at all. The problem with doing it with your best friend is your best friend remembers that you were the chief resident and you were like always ace the creog, so they're going to cut you slack when you say things. If you try to use your chairman in your department, they'll do like 20 minutes with you one time, and that's all great and it's certainly helpful, but then it's not going to be on a regular basis. I don't know if you're planning to take an Exam Pro course or if you've taken one, but I would try to get the name of somebody who's taking the test the same month you are, preferably a stranger. Exchange lists and make an hour each week that you're going to do a half an hour asking them questions from their list, and they're going to do a half an hour asking you questions. It's immensely helpful.
Okay. I mean, because I know for myself, probably doing a mock oral once a week won't be enough. So I don't know if there's like a ballpark number as to what we should be hitting to feel prepared, but that's probably just individual.
Well, the thing about what I was suggesting with the hour a week of the mock orals, if you do that and you start now, you'll get through all 3 lists. So you may not, cover case of the day stuff, but it won't be the first time somebody's looked at your list and asked you, about a certain condition. And so it'll be more familiar to you. It won't be the first time you've heard it when you're in your test. I always tell people problem cases are only problems when you discover them as a problem during the exam. If you've anticipated it before, sometimes there's not a lot you can do about it other than to be contrite. And it's like, if I had this patient to do over again, or in preparation for my boards, I realized that I should have done X. It may even come down to that. But better to know that and be prepared for it going in than trying to fumble your way through it when you're sitting there.
Sure, yeah. That
Okay,
makes sense.
I hope that we're very good. Anybody else have any questions or comments about anything that we've talked about? Okay. Let's see. Tiffany, I'm trying to unmute you if you're unmutable here.
Hi.
There you go. Hey, Tiffany, are you a generalist or specialist?
Generalist.
Great. All right, I'm going to just make one up because we don't have a lot of time here. So can you tell me, we didn't do recurrent yeast the other night, did we?
No.
If you don't want to just say, yeah, we did actually.
You said recurrent yeast infections, right?
I did.
Okay.
So what's the definition of recurrent yeast infections?
To my recollection, it's at least 4 yeast infections in the span of a year.
Okay, can you tell me what are risk factors for recurrent yeast?
I often counsel patients about not douching and like washing with just like water, warm water down there instead of like using soap. Use of antibiotics. Some patients are prone to developing yeast infections after taking antibiotics. Some patients may be prone to yeast infections if they're wearing like restrictive clothing. Those are the ones that I can think of at this time.
Okay, so if you had a patient that came to see you complaining of, let's say, her 5th yeast infection this year, so tell me, how would your workup for her differ from somebody who came in with, let's say, a random or isolated yeast infection?
Thanks. So now you've triggered additional risk factors. I would make sure that she doesn't have diabetes or HIV, or she's not immunocompromised, because that would also increase her risk of having recurrent yeast infections. And then if she is an established patient and then she has like documentation of multiple yeast infections like we described, then I would offer her a 6-month course of diflucan. If she was a new patient, I would encourage her to come in and get a swab every time she had symptoms so that we could establish the diagnosis and establish that she actually does have yeast infections and not something else.
Okay, so this time though, she's coming in with her 5th time. So what would you do, cultures of the yeast or anything like that?
Yes, I would do, aside from the test for HIV and diabetes, I would do a swab, and I would also check to see if it's like Candida albicans or Candida glabrata and go from there.
How would you treat her if she had an atypical yeast? Let's say she had glabrata.
Glabrata can often be resistant to fluconazole, so another option would be boric acid for 14 days.
Okay. What lifestyle modifications would you recommend for a patient who has recurrent yeast?
Sometimes yeast infections can be associated with their diet, so, and especially if they're eating like sweeter or more carbohydrate-rich foods. So I would advise them to try to see if there's any triggers and avoid those. Also, like I said before, like trying to wear non-restrictive clothing, because sometimes that can be a trigger as well. The literature doesn't really show that it's shown to be effective, but I don't think it hurts to also advise them to take a probiotic to see if that kind of strengthens or normalizes the normal vaginal flora and prevents yeast infections.
Be careful with mentioning literature because if it were earlier in the evening, I'd probably ask you about what literature you're referring
Gotcha.
or
Okay.
whatever. Okay, good. Let's see. And one last question. So let's say she had albicans and you determined that it was recurrent. She didn't have diabetes and she was not HIV positive. What treatment regimen would you recommend for her?
So I would prescribe fluconazole, 150 milligrams, and she would take it 1 tablet every 3 days for the first 3 pills, and then one tablet per week for the next 6 months.
I'm sorry, you said 1 tablet every 3 days or for 3 days?
I believe it's 1 tablet every 3 days for the first 3 doses, if I remember correctly.
Okay. All right, very good. Nice job. So I thought, pretty much everything you said was correct. Just going to run through some risk factors for recurrent yeast. So you mentioned antibiotics. Steroids would be another. Pregnancy would be another. Obesity would be another. You mentioned diabetes and HIV. Birth control pills can technically predispose a patient to yeast infections. You said antibiotics. Those are the ones that are coming to mind, at least right now. So your workup, yes, you'd want to do a yeast culture, as you said, looking for an atypical. And you talked about Glabrata with the boric acid, which I thought was good. Your regimen is fine, and your lifestyle modifications basically are just hygiene related. You said no tight undergarments, either underwear or jeans. Wearing preferably no underwear in the evening or at night when she's sleeping, rather. Cotton underwear when she does wear them. If they're diabetic, of course, optimizing sugar. And you mentioned the carbohydrates. Obviously treating HIV if she's HIV positive. And, if there's an alternative to the steroids, at least for, periodic breaks, if she's on chronic steroids, that would be helpful. Antibiotics, again, treating the patient right after their course of antibiotics. I think that's it. I think we covered everything, right?
You answered all my questions.
You did a nice job. Thanks, Tiffany. All right, last call for questions. Thank you. Last call for questions, guys. Maria?
Yeah, this is really quick. I've had a couple of people review my case list, including ExamPro, and I just want to see if you just know a final answer. But for the OB list, for patients that I admitted but did not deliver, do they need to be included, is my impression. I just have had a lot of feedback that they do not.
Yeah, if I recall correctly from the bulletin, I think they don't. But, if you admitted a patient, let's say for, PROM at 32 weeks or whatever, and let's say she got steroids and latency antibiotics and, all that stuff, and then, let's say 10 days later either developed choreo or went into preterm labor and your partner delivered her, but you were managing her all along, I would list her. And I would list her and I would put, SVD at 33.5 weeks, whatever, by colleague. They don't want you, if you didn't do the delivery though, one thing I know for sure, they don't want you to list the delivery information. So you wouldn't list the weight and the APGARs.
Gotcha. Okay.
But, if you admitted the patient and you care, look, if you admit somebody, tomorrow morning because you're on call tonight, and get her started with Pitocin for an induction and then sign out at 8 o'clock in the morning and she's like, 1 to 2 and 50%, whatever. And your partner comes in and delivers her, I would not list that patient.
Okay. That sounds reasonable. Okay. Thank you.
And again, some of it's some of it's like using logic and common sense. And the big question is, in the extreme unlikely event they audit you, can you defend why you did or didn't list them?
Okay.
So, all right. Well, guys, thank you all very much. I know there's someone else conducting the webinar tomorrow night. I will look forward to speaking with you guys next Sunday. Hope you have a wonderful week. Good night.
Thank you.
Thank you.
Thank you. Thanks.